Is the screen visible?
Yes, sir.
So, thyroid and anesthesia, these are all the common things they may ask you. Anatomy and embryology, physiology of thyroid hormone, hyper and hypothyroid conditions, antithyroid drugs and thyroxine pharmacology, indications for thyroid surgery, pre-op evaluation, intra-op management and problems, post-op problems and management, uncontrolled hyper or hypothyroid patients for non-thyroid surgery or requiring surgery for correction of unresponsive to medical treatment itself. So all these things are the common questions that may be asked in the examination. So these are all the things first you have to remember. The name, why it is called thyroid? Because it is a word meaning shield. It looks like the shield of the Greek and Roman soldiers, which they used to. This is the embryology. The development starts as early as third week, and by seventh week, the gland reaches the final position to the larynx and the trachea. And but in the middle, may get arrested anywhere, and that will be called ectopic thyroid. If they are situated elsewhere other than the normal position, they are called ectopic thyroid. And these are all the anomalies that can happen. This is the foramen cecum at the base of the tongue level. From there, it travels down, comes in front of the hyoid bone, and then the thyroid cartilage, and comes down to this position. So these are all the locations where it can get arrested, and it can be a lingual thyroid, or it can be in the form of thyroclassal cyst or thyroid sinus and retrosternal goiter. It can go down also. So these are all the anatomical extent C5 to T1 level, that is the lateral vertebral level, and in front of the neck, if you see, it is extending each middle lobe from the middle of the thyroid cartilage to the tracheal ring, and the isthmus is in 2, 3, 4, which is important for. So you do a tracheostomy here, normally below the isthmus level and not at the higher level to avoid damage to that. So the reason why the thyroid gland moves with deglutition is because of this. What is called the suspensory ligament of Berry is there, which is nothing but a condensed connective tissue which holds this to the thyroid cartilage and upper tracheal links. And the ligament of Berry and pretracheal fascia are responsible for the movement of the gland with deglutition. And this is the arterial blood supply. Superior thyroid from external carotid, then the inferior thyroid artery from thyrocervical trunk. And very rarely you have a middle cervical. So arterial supply is mainly from these two, that is inferior and superior. You normally don't have a middle thyroid artery. You have only a superior and inferior thyroid artery. Whereas the venous drainage, you have the three areas: superior, middle, and inferior. It is a small. Some very rarely you may have what is called thyroid ema artery from the aorta directly. That is only in 3%. Okay, so only 2 arterial supply and 3 venous drainage. That is the important difference that you have to remember. And this is what is called the Riddle's triangle, where the recurrent laryngeal nerve is there, which is likely to get injured. And this nerve is identified down the trachea and the esophageal groove. And the nerve forms the third side of what is called the Behar's triangle. So these other two sides are the common carotid artery and inferior thyroid arteries. So that is the location for safeguarding the recurrent laryngeal nerve from injury. And the physiology of thyroid hormone. This is a common question. They may ask you how the hormone is formed by the thyroid follicles in the thyroid gland, and the blood which carries the iodine. The iodine is taken up by the follicular cells through the sodium iodine importer. So both the sodium and iodine are coming in and then the iodine will be sent, the sodium will be sent back by the sodium potassium ATPase pump. But the iodine will travel through and go into the well-like area inside the follicle. And there only the iodinization occurs, and then it is stored back in the thyroid follicular cells. And then it is whenever the TSH comes and activates that, it will be released like you can see in this picture. There is an endocytosis and proteolysis happens, and thyroxine and that is T4 and T3 will be released into the bloodstream by the action of the thyroid stimulating hormone. And these are all the normal values of how much of T4, how much of T3, and how much of reverse T3 are all produced. So 100 nanomoles is the T4 value, 5 nanomoles for T3 and reverse T3. And T3 is the most active form. That is the important question they may ask you in the exam. And so T4 has to be converted to T3 for its action. So it is called the pre-hormone. Reverse T3 is a metabolically inactive part of the hormone. And thyroglobulin is the pro-hormone where it is stored in the form inactive form and then released before you want to get the active form. And how it is converted? It is by removal of one iodine at the position, which structure I will show now. So this is the normal feedback mechanism which all of you would have studied in your physiology days. So, and how to interpret the thyroid function test, the TSH value, either normal or increased or decreased. So in the normal position, increased position indicates there is a hypothyroidism. To stimulate the gland, TSH will increase. And it can be normal only if the pituitary is also affected. So it can be primary or secondary. In primary, there is a autoimmune thyroiditis, a common condition where T4 value is also decreased and TSH is increased. Whereas in secondary hyperthyroidism, T4 value will be normal or slightly increased, and in subclinical it will be equivocal. So that is how the whole thing is there. Either it can be primary, secondary, or subclinical. These are all the three clinical presentations interpreted by the thyroid function test. Now this is the structure of thyroid hormones. So levothyroxine T4, you can see it has got 4 iodine at the 3 and 5th position. There are 2 benzene rings attached with an oxygen, and you have the iodine at the 3rd and 5th position in both the rings. One is called the inner ring, other is called the outer ring. And in active T3, you have the iodine position in the outer 3 and 5 with only one iodine at the 3' position. Whereas in the reverse T3, you have the opposite. The 3 and 3' positions, you have the iodine, and in the 3 normal position, you have only one iodine. So that is how the structure. Sometimes they may ask you to just draw this position alone. So please remember, you have to just put 2 benzene rings, attach it with the oxygen, and then draw the iodine at all the 4 places for T4, and for the T3 it has to be 3, 5, 3 dash. Here for reverse T3 it is 3, 3 dash, 5 dash. So that is how the whole thing is described. And how TSH acts, it's acting through the GS coupled receptors, including so TSH will come and attach itself to the outer portion of the cell, and then intracellular signaling will happen, which will stimulate the G stimulatory protein, which will increase the ATP cyclic AMP protein kinase A, and it will go to the follicle cell and cause all its action of causing the release by ectocytosis of the earlier follicle which we saw. So the initial step in thyroid hormone synthesis is also the same route that which we have already seen in the other picture. Now these are all some of the actions of thyroid hormone which they can ask you. So T4 has to enter the cell of any level. For example, here liver, pituitary, brain, or heart, all these cells, will permit the T4 to come inside, and there it will be deiodinized to produce active 3 form, which is a hormone which will act on the nuclear receptors. So nuclear receptors will be activated, messenger RNAs will be stimulated, which results in new protein or enzyme formation, and then it causes all the various actions of increasing growth, temperature homeostasis, oxygen consumption, metabolic rate, basal metabolic rate maintenance, and beta adrenergic receptors. These are important 4 actions of your thyroid hormone: growth, temperature, oxygen consumption, and BMR, beta adrenergic receptor activity. That is why, because of the beta adrenergic receptor activity only, in thyrotoxicosis or hyperthyroidism, you get increased tachycardia and all the beta adrenergic manifestations because of this particular action of the thyroid hormone. Now, functions, it acts on the general metabolism, growth, respiration, cardiovascular system, gastrointestinal reproduction. So it has actions on almost all the various organ systems, nervous system, carbohydrate metabolism, protein metabolism, lipid, everything is there. Now, the one question in the exam that may ask you is, what is BMR? It is the amount of energy liberated by breakdown of food per unit time under standard conditions. And what are the standard conditions? Patient must be in a relaxed state at a comfortable temperature, and it should be tested after 12 hours of a meal. And it should be corrected for age, sex, and body surface area. These are the three prerequisites for taking the BMR calculation. Now, it is determined by heat produced by the subject or oxygen consumption that is done by that. This is the way it is measured, the BMR. And the value of normal BMR for an adult is 197 kilojoules per square meter of body surface area per hour, or 40 calories per square meter per hour. This is the way it is expressed. In hyper and hypothyroid conditions, what happens, all of you know, it can be, hypothyroidism can be primary, secondary, or tertiary. Causes of primary or iodine deficiency or excess iodide intake, thyroid ablation after surgery, or Hashimoto's thyroiditis, or inflammation like subacute thyroiditis, or genetic abnormalities, and some drugs like lithium, amiodarone, and antithyroid agents. All these things can lead to hypothyroidism, which is of primary origin, where PSH is elevated and T3, T4 will be lower. In secondary, it is secondary to hypopituitarism, which can be in the form of adenoma or a pituitary ablation or pituitary destruction. In tertiary, it's very rare and it happens at the hypothalamic level. And hyperthyroidism, the causes usually are overproduction of thyroid hormones, as happens in Graves' disease or pituitary adenoma, multinodular goiter, leaking thyroid hormones, drugs like thyroid replacement drug, thyroxine itself. Amiodarone, this is one peculiar thing is amiodarone can cause both hypo and hyperactivity. Whichever way it can manifest. And iodinated radio contrast agents and metastatic thyroid carcinoma, all these things produce hyper conditions. And how to diagnose all that, you probably know biochemical values. In primary, what is happening is, and there is one misconception. Thyrotoxicosis is frequently confused with hyperthyroidism. Both are used synonymously because hyperthyroidism is defined as an increase in thyroid hormone levels in the thyroid gland secretion or synthesis, whereas thyrotoxicosis is a group of signs and symptoms induced by the hormone's activity. So both are not same. You cannot call every patient as a thyrotoxic patient. It is only the increased activity of the hormone which is exhibited as severe tachycardia, heart failure, rise in temperature, just like a thyroid storm. It may be of varying degree. It may be mild, moderate, or severe, but it is the hyperactivity of the hormone is called thyrotoxicosis, whereas increased production of hormone is called hyperthyroidism. That is the difference between the two things. The features of thyrotoxicosis, all of you know why it happens. It's a hypermetabolic condition caused by the elevation of thyroxine and beta adrenergic upregulation and sensitization to catecholamines happens. So the conditions which result in thyrotoxicosis can be Graves' disease or toxic multinodular goiter, adenoma, and other iatrogenic causes of excessive thyroxine intake. And the most important point is if any thyrotoxic patient is coming for surgery, he must be biochemically and clinically made euthyroid before surgery to avoid the complication called thyrotoxic crisis or thyroid storm. So the risk of perioperative thyroid storm is usually higher following acute event like surgery, trauma, or infection. So even if a patient is not undergoing surgery, if a thyrotoxic patient who already exhibits the increased activity of the beta adrenergic system, we will have the chance of going in for thyroid storm if there is a injury to them or even febrile illness, they can go for this particular problem. So that is the reason why hyperthyroidism should be controlled very well. Any idea what is this apathetic thyrotoxicosis is? You know the answer for this apathetic thyrotoxicosis. Normally, what will be the behavior of a thyrotoxic patient? They be very calm or agitated or restless or very anxious. What is
anxious and agitated, sir.
Anxious or agitated, restless. Okay, whereas in the patient who has a cardinal features of apathy and depression, in contrast to excitability and hyperkinesia, they are called apathetic thyrotoxicosis. And usually it happens after radiation of thyrotoxicosis, which is not well controlled with drugs alone. So those patients go in for this particular condition called apathetic thyrotoxic. Tachycardia, the elevated values of all the T3, T4 and all that, and differential diagnosis of thyroid storm. That is a common question they ask you. They are sepsis, which will also produce a similar picture of high temperature, tachycardia, uh, dehydration, cardiac failure, all these things can happen. Then malignant hyperthermia, MH, neuroleptic malignant syndrome, serotonin syndrome, anticholinergic syndrome, pheochromocytoma, and iatrogenic. All these things can produce raised temperature and features like that. Now, to assess the degree of thyrotoxicosis, there is a scale called Burke and Warthof scale, point of scale. So here you have the 5 parameters which are to be taken into consideration. One is called thermoregulatory function, how much of temperature increase happens. Then cardiovascular system, tachycardia, arrhythmias, congestive failure. These three things are taken into consideration. GI tract and hepatic dysfunction, CNS disturbance like absence, agitation, delirium, psychosis, seizure, coma, and precipitating event, whether present or not. All these things taken together, if you have more than 45, it is a confirmation of thyroid storm.
Yes,
if it is 25 to 44, it is an impending storm, and if it is less than 25, it is not likely to be thyroid storm. So this assessment scale will help you to confirm the diagnosis of thyroid storm by taking into consideration these 5 parameters. And the prerequisites for thyrotoxicosis to happen is elevation of the T3, which is the more active form. So manifestations in a conscious patient, it will be restlessness, delirium, psychosis. Temperature will go up, tachycardia will be there, congestive heart failure can happen, GI disturbance, like in a conscious patient, it will be nausea, vomiting, diarrhea, and of course, how to grade that is also given here, which is called the Akamatsu diagnostic criteria. That is only for students who do very well. They may suddenly ask you to floor you with these questions. And how to manage thyroid storm from theory point of view, you have to know all these things, general considerations. If it is happening during the surgery, inform the surgeon, declare an emergency, call for help, and protect the airway in an awake patient or administer supplementary oxygen, increase FiO2, optimize ventilation in intubated patient, consider differential diagnosis, treat the trigger, and refractory diseases, consider thyroidectomy after the procedure. Thyroid storm complicated with acute hepatic failure, consider plasma exchange. These are all two extreme cases, and how to manage that is given in that. But the common methods of management should be told in the examination. It is mostly symptomatic and supportive. And you can decrease the effect of thyroid hormones by preventing further release as well as neutralizing whatever has been given by giving iodine and antithyroid drugs by nasogastric tube into the stomach, like carbimazole and propyl thiouracil. All these things can be given, and you can give iodine also to suppress the further release of the thyroid hormone. And hypothyroidism, there is a condition called central hypothyroidism, which is often suspected in patients with hypothalamic or pituitary pathology. And the fractional pre-thyroxine index is the diagnostic test which helps to identify the central hypothyroidism. It can be calculated using this, and these are the concentrations to be measured to find out hypothyroid state. Interpretation of the results, already we have seen that. Thyroid malignancies. What are all the types of malignancies you can get? You can get the papillary carcinoma, follicular, medullary, and anaplastic. Of this carries the best result, 90% 20-year survival. So if identified, better to do total thyroidectomy as early as possible. And antithyroid drugs, their pharmacology is another question that can be asked. So classification of antithyroid drugs can be in the form of inhibition of hormones by carbimazole or the prodrug methimazole and propyl thiouracil. Inhibition of release, which is by iodine, iodide, and organic iodide, and complete destruction and prevention of hormone release is by radioactive iodine. This is mostly for very severe Graves' disease, where the thyrotoxicosis is very severe. You can give this. Then ionic inhibitors like the thiocyanate, perchlorate, and nitrates. And commonly, this is for more theory questions. We can have a theory question on pharmacology. Of course, in the last exam, they didn't ask anything much on pharmacology at all. But sometimes the earlier questions, you have the comparison between propyl thiouracil and carbimazole. You had a comparison between propofol and thiopentone. You have a comparison question between anti-epileptic drugs like phenothiazine and phenobarbital and benzodiazepam. So like that, earlier they were asking all pharmacology questions. So for that sake, I have just put a comparison between propyl thiouracil and carbimazole. And the Lugol's iodine. This is one question the examiners are fond of asking. So a very vascular tumor, if the surgeon wants to do a thyroidectomy to reduce vascularity, they can administer a drug called Lugol's iodine, which is 5% iodine in 10% potassium iodide, and the dose is 5 to 10 drops per day. So as long as you give, And the common question is how soon after stopping this drug you should operate on the patient. This is given to reduce the vascularity and the intraoperative bleeding. So you start it at least 1 week prior to the surgery, and then you stop that. And how long you have to, or what is the window period within which you have to operate?
12 to 24 hours.
Not so short. It is as early as big as 5 to 7 days. Okay. After stopping lugalsiding, you have to operate within 5 to 7 days to achieve the reduction in vascularity. Otherwise, the gland will again receive the full blood supply again. And this is a hypodate, which is a contrast which is given for treating thyroid storm. So, in addition to the regular drugs, you can remember this also, which is given as a measure to treat the thyroid storm. And this Wolff-Chaikoff effect is another thing that is asked with regard to the iodine treatment. It is a protective mechanism that reduces thyroid hormone production in response to high levels of iodine. So if you give lugalsidine, this will also help in reducing the production of thyroid hormone in hyperthyroid patients. Now, radioactive iodine and beta blockers, they are all symptomatic treatment for controlling hyperthyroid state. And for hypothyroidism, we always have to supplement the thyroxine. That is, the hormone has to be given. All of you know it is given as levothyroxine, available in 150, 25 microgram tablets. It has to be given as a oral medication first thing in the morning with 6 of water. So all hypothyroid patients, we have to ask them whether they have taken their replacement when they come for surgery, and it can be administered with 6 of water on the day of surgery also. And it is available as a parenteral injection form, as a levothyroxine is available for ICU use in patients who suffer from myxedema coma. So it is the opposite of thyrotoxic crisis or thyroid storm, where patient has extreme degree of hypothyroid function, where patient will become hypothermic, comatose, have a deranged cardiovascular function, and so in those patients you can give T3 as a injectable form to correct that particular situation. And the indications for thyroid surgery: malignancy or thyroid gland with obstructive symptoms, retrosternal extension with obstruction, hyperthyroidism which is not responding to medical therapy, or recurrent hyperthyroidism. It may be for cosmetic purpose or patient's anxiety. In a euthyroid case, where the thyroid function is normal, it is neither hyper nor hypo, but the swelling may especially look very not very so appealing. So for cosmetic purposes, you may be patient may be undergoing surgery. And Hashimoto's disease or hypothyroid goiter with superimposed lymphoma are all conditions where thyroid surgery is done. During evaluation, you require these gadgets or equipments: a stethoscope to auscultate for breathing, a glass of water for asking the patient to swallow with this, and a knee hammer for judging the wrist tendon. Wrist will be more brisk in patients with hyperthyroidism, whereas hypo it will be sluggish. And you have to inspect, the inspection have to be done from front as well as from the lateral approach. And clinical examination, first you start with the hands. Of course, after examining the gland and the local examination for signs of hyper or hypo, you have to look at the hands, where it may be sweaty, warm, or dry and cold in hypo. Clubbing may be there in thyroid arthropathy, and onycholysis, that is, nails may be destroyed, and you may have palmar erythema or pallor of palmar crease, maybe tremor may be present, Muscle wasting will be seen in hyperthyroidism, whereas puffy hands in hypothyroidism, and carpal tunnel syndrome. You just press here, patient will have excruciating pain in the median nerve distribution. So that is the carpal tunnel syndrome and hypothyroidism. And pulse you have to examine for rate, rhythm, and volume. In hyper, you have tachycardia, irregularity. Hypothyroidism, you usually have mild bradycardia. Respiratory rate, blood pressure, temperature, all these things vary in these patients. So these are all the things that has to be described to rule out that the patient has hyper or hypo. And then these are the various eye signs which the examiners sometimes ask you ask you to describe. This is called the pre-TPL eczema in hypothyroidism, myxoma. And this is Koch's sign of staring look. And this is how you examine the gland from front to the upper and lower extent. And this is how you do the thyroid swallowing test. Can also watch as well as palpate the gland while the patient is swallowing. This is the suprasternal notch percussion to rule out the retrograde retrosternal extension, and this is auscultation for Brugge. And this is the Pemberton sign to make sure whether there is any venous obstruction happening. You can see the patient's face in the normal position, and when he raises both the hands, the whole face becomes congested and suffused. These are all the changes that happen between hyper and hypothyroidism. What investigations you have to do is all the blood test, X-ray, ultrasound. Whenever patient comes for total thyroidectomy, especially serum calcium is very, very important, so that you know whether the patient is going in for hypocalcemia after surgery or whether he had a low calcium even before surgery. And this is how the values are evaluated. This is the X-ray showing the compression. So this is just for the ASCII sake. I thought I will put this so that you will remember. Compression and deviation of tracheal ear shadow that happened because of this. And this picture, widening of upper mediastinum by retrosternal goiter. You can see there is a widening of the, normally it will be a very narrow portion. It is widened because of the retrosternal goiter. And the anesthesia of choice is GA with endotracheal intubation. Precision of the patient will be supine with neck extension, and eye protection is important. IV line placement is very important because it should have an easy access. So choose a IV line as peripherally as possible, either in the dorsum of the hand or in the dorsum of the foot. Or if you have a dorsum of the hand, you have to have a long extension line so that you can inject your drugs easily. And pressure points to be protected. Choice of the EP tube between the three tubes what she mentioned. And, earlier days they used to leave the patient on spontaneous ventilation also for minor small gland resections. But controlled ventilation is the dictum that is followed now. So this is the armored tube which normally we use. This is the North Pole nasal ray tube. This you don't have to put it through the nostril, you can put it orally. So the only indication for a North Pole or a nasal ray tube to be used orally is thyroid surgery. Okay? This is the EMG tube mounted on a trackway. So you have the stimulating wire, everything is there that will be attached to that after intubation. So whenever the surgery is going on, you can stimulate the nerve. The only requirement is at the time the effect of your muscle relaxation should be very low, so that the muscle can be stimulated by the nerve and you can get the effect, whether you can see that. So this is the normal position, and how you safeguard the tube and prevent it from compressing on the patient's eyes and other vital organs on the face. So always give a soft support for the patient. And the placement of electrodes. You can see normally you put it on the chest, but here you put it on the two shoulders and the hip, so that it doesn't come in the way of painting and draping. And headrest, we use this sort of headrest with a gap so that there is no pressure on the head. And we some strategies to attenuate hemodynamic response and coughing and straining when you want to extubate a patient after surgery. This can be practiced for anything. One choice is deep extubation. With an uncomplicated airway, you can extubate, if you can re-intubate the patient easily, you can extubate the patient in a deeper plane of anesthesia. And daily maneuver, which involves inserting a deflated laryngeal mask airway behind the endotracheal tube, and then you remove the endotracheal tube, inflate the laryngeal mask airway so that you can avoid coughing and coughing. This is mainly for neurosurgical patients where you don't want the intracranial pressure to go up. Then laryngotracheal anesthesia with topical lignocaine. And spray that, or you can use alkalinized lidocaine in the ET tube cuff itself for short surgeries. Instead of filling the cuff with the air, you can use lignocaine, which will slowly seep out and anesthetize the area of contact so that the patient will not buck or cough during extubation. And the administration of dexmedetomidine, small dose before extubation, and low dose remifentanil infusion can be continued. So these are some of the things that may be asked in the viva, how to avoid bucking and coughing during extubation. Regional techniques for thyroid surgery. Some of the papers have been done earlier. For small resection of or a hemithyroidectomy, you can use these techniques, which is nothing but a superficial cervical plexus block, which is given by this, the sternocleidomastoid, the lateral border. You inject in the middle and then turn the direction upward and downwards, and we will require about 15 to 20 ml of local anesthetic. So that will take care of all the skin supply in the front of the neck. And deep cervical plexus block is given here. And this is the cervical epidural, which also has been described. So from theory angle, supposing they ask you what are all the regional techniques for thyroid surgery, you can mention all these things. And intraoperative complications, thyroid crisis, hemorrhage, hair embolism, need for sternotomy in retrosternal goiter, and the newer challenges, intraoperative neuromonitoring. It is recurrent laryngeal nerve monitoring, intraoperative neuromonitoring. Endoscopic thyroidectomies are also now coming into practice to avoid ugly scars on the scars in the neck, especially for people in the film industry. If they have to undergo, they don't want that. So this is the axillary approach to thyroid surgery. So they make two ports and they do the introduce the endoscope to the neck and dissect the thing. This is the chest approach to thyroid surgery. Transoral or robotic thyroidectomy is also. So you can see this is the transoral route where they have put through the endoscopes the approach the thyroid. And the complications after can be classified as immediate, intermediate, and late. So immediate is recurrent laryngeal injury will be immediately seen, and tracheomalacia and laryngeal edema also will be happening immediately. Intermediate things are hematoma. Late complications are hypocalcemia. So these are the common things that they ask you. These are the different types of Analysis, they can ask you in the exam. This one repeated question in theory, various types of referral laryngeal nerve injury. So this is the Malaysia, which you can see. Malaysia normal view through endoscope. So on the left you see the Malaysia, and complete test. So after a huge thyroid, if you want to diagnose Malaysia, even before you extubate, you do the cuff leak test. So if you hear a exhaled volume of no leak, means no sound on auscultation, that means the collapse is there. So even after deflating the cuff, if you don't find the leaky noise, that means there are tracheas collapse. Don't extubate on such cases. Wait and either extubate on a airway exchanger so that you can re-intubate or plan for a elective tracheostomy and then extubate. So that is the important thing. So long-standing goiter where tracheomalacia is suspected, this simple cuff leak test will tell you whether to safely extubate the patient or not. And these are some of the newer things that are come up in the guidelines. Post-thyroidectomy surgery, which is called the DSATS, difficulty in swallowing or discomfort after surgery, early warning signs, swelling, anxiety, tachypnea, difficulty in breathing, or stridor. All these things indicate that patient has, these are the things post-operatively observed, have to do that so that you can immediately manage that. And it is due to suspected hematoma following thyroid surgery. So this is the flow chart or guidelines that can be sometimes asked in your exam. Nowadays they are asking from all the journals and other things, the questions are coming. So management of suspected hematoma following thyroid surgery. This is the flow chart that you have to remember. It's available next. So, management of post-op hypocalcemia, you have to measure the calcium level. And then if it is more than 8 and patient does not have any symptoms, just continue with the regimen and watch for the, just observe the patient. And when the levels is 7.1 to 7.9, patient with mild symptoms, give extra dose of oral calcium. And then if the symptoms do not resolve, give IV calcium gluconate. And start calcitrol 0.5 microgram orally twice a day. The increased frequency 4 times a day. Replacement of magnesium is also indicated if it is low. Then only the whole thing will resolve. Then if the symptoms don't resolve, then you have to give IV infusion of 2 grams of calcium with 100 ml of saline for over 1 hour. And if the value is so low as less than 7 milligram, first give IV calcium gluconate, start calcitrol like in this case, increase frequency, and again here the dose is 5 grams instead of 2 grams. So in patients with very low magnesium level, calcium level of less than 7, the infusion rate is 5 grams in 500 ml at a rate of 50 cc per hour. Whereas if the patient, if you have suspected hypoparathyroidism because of excision of parathyroid, you can measure the measurement of parathyroid within 6 to 6 hours post-operatively. If the value is more than 1.7 picomoles, then start calcium supplement, monitor for hypocalcemia. It will not be very severe, add vitamin D also. But if the value is more than 1.7, that means it's normal, no need for any supplementation. Patient can be discharged after 24 hours. So that is the two things you have to differentiate, whether it is due to hypoparathyroidism or removal of parathormone from the system, or whether it is simply calcium insufficiency by the value of calcium. So Recommended contents in thyroid surgery emergency is recommended now to remove any hematoma formation. This is called the scoop. Skin exposure, cut the sutures, open skin, open muscles, and pack the wound. So that is all the current things in thyroid management. So one more thing, some examiners are fond of asking about flow volume loops in obstruction due to thyroid. Okay, so you have to know the difference between extrathoracic, fixed obstruction, all those flow volume loop discussions we had in the OSCE that can be handy and useful to answer if you know that or if remember that points. So this is what we have to remember.